everyone. Welcome to this special podcast episode. My name is Will Martin. I'm joined by Paula Azuaje, and we will serve as your hosts today. We're really happy to have Anita Case, the Executive Director at Affinity Health Center, join us. She earned her master's degree in social work from the University of North Carolina in Chapel Hill. She's been working in healthcare since 1997 and has been in her current position at Affinity since 2005. Affinity Health Center, to give some background, is a not-for-profit community health center that offers comprehensive and compassionate care with the specific mission of serving the uninsured and underinsured. They have primary care, on-site pharmacy, on-site dental, case management, HIV specialty care, and HIV, hepatitis C, STD testing. So today, we really want to focus on that last part, the HIV, AIDS, specialty care, and testing. This has a lot to do with Affinity's history as an organization. So Anita, can you tell us a little brief overview of Affinity's history and role with the HIV/AIDS care community to start us off?
Sure. Thanks, Will and Paula. So we actually opened 20 years ago as an HIV service organization, and our focus was really providing support services and bringing HIV specialty medical care to this community here in Rock Hill, South Carolina. At the time, people living with HIV were traveling to Columbia or Charlotte to get specialty care, and some advocates in the community got together and formed this tiny little nonprofit and said, let's do something better here in York County. So we started with 4 employees 20 years ago and some basic services related to HIV. We have been providing HIV care for the last 20 years, but about 5 years ago, we transitioned to become a community health center and expanded our services to the broader community. So we have about 700 HIV positive patients that we take care of and about 7,000 primary care patients that we take care of.
Okay, great. And before we get into more specifics, can you just give your best quick explainer of HIV and AIDS? And maybe, I think there's a lot of misconceptions about it out there. And so I'd like your expert overview of the disease.
Okay. Well, HIV is the virus that attacks the body's immune system and allows other infections and things to attack the body. So a lot of people, if people are dying with AIDS, it's usually because they have another condition that attacks their body because they have a compromised immune system. The field of HIV has changed significantly since I started in 1997 in this field. At that time, people really were having a really hard time managing the disease. More people were dying from it. The medications were very complicated, and it was very hard to work and take HIV medications. So a lot of people were on disability and stuck at home. So now the treatment is so great that really people can live a relatively normal life in terms of their physical health. They can take 1 pill a day and with very minimal side effects. And as long as they're consistent with that, they could live a normal, healthy lifespan. So HIV has changed a lot in the last 30 years to be a more manageable chronic disease, although it is still terminal. So it's still, if someone doesn't take treatment, they will still die from it. So I think that's the hard part. It is manageable. We have great treatment for it, but if you're not getting treatment, then you still will die from it.
Right. Okay. Very good explainer there. So as Paula and I were doing research on you and HIV/AIDS as we started to prepare for this episode, we found a Q&A online, and you talk a lot about at age 11 when your uncle was diagnosed with AIDS. And you had a lot of experiences with that. So we want to know a little bit more about why HIV/AIDS prevention and care is important to you just personally, and maybe share a little bit of that story.
Yes, when I was in the 6th grade, my mom's brother was diagnosed with AIDS, and at the time it was, we didn't know much about it. This was in the mid-'80s, and so HIV wasn't even a term. It was actually called gay-related immune deficiency. It was mostly occurring in gay men. My uncle was married with 3 children, and he actually contracted it because he was a hemophiliac and took blood transfusions on a daily basis. So actually, what he was taking to survive ended up killing him. But at the time, pretty much all hemophiliacs ended up getting AIDS, and most of them died from AIDS. I was an impressionable 11-year-old, and fortunately, my family was very public about my uncle's diagnosis. His wife was very public. At the time, they lived in a small rural community that really shunned them, but they still decided it was important to advocate and to educate people because there was a lot of fear. You know, even doctors were afraid. They would suit up like astronauts, kind of like when we do COVID testing now. They would suit up, because they didn't know, they weren't sure exactly how it was passed. I mean, there were still a lot of questions and a lot of stigma. So my family got very involved in advocacy work, and I remember talking to my 6th grade, 7th grade classmates about condom usage. I mean, it was like this, we just really got engaged in not only advocating for people living with HIV, but educating people that it is sexually transmitted, and that, that you can prevent it with safe sex practices. So I was impressionable, and it landed me where I am today. I did a lot of middle school projects about HIV. My mom was a hospice volunteer, and she was the only one who would work with AIDS patients in our small town that I was living in. So she would take me with her to visit patients. And I think it just really made an impression on me that so many people shunned them, and they were really not welcome in their families, and families were afraid to be with them. And so I think felt this kind of calling to, that this was a community that needed something. And so that held on tight, I guess, until I graduated college and got an internship right after college working at an HIV organization in San Francisco. And I guess there really confirmed my passion to do this work.
So
Yes.
do you think that this situation with your uncle made you much more comfortable interacting with HIV/AIDS patients in the future down the line, and that you were like less scared of touching them, being close to them? And
Yes, actually, my uncle and his family lived with us. So, we shared bathroom, we shared meals, and that was, I think, a big part of the advocacy work that my family did. Is, well, this is not casually passed, and so yeah, he lived with us, and other than being in the hospital, which he died in the hospital, but he and his family were living with us at the time. So I think it was never, in my family, it was never acceptable to have that misunderstanding or that lack of knowledge on the disease, and it was never acceptable to shun people. So I think absolutely it made a big impression. The sad thing is 30 years later, there's still some of those misconceptions. We still have HIV positive patients who have family members who are afraid to be with them, to share food with them, who there's still that very outdated fear that's not based in reality.
Okay, interesting. So tell me a little bit about what you see in history as maybe the key turning points in both the treatment and perception of HIV and AIDS. Like I can kind of think back to like me personally having not really been involved with this. Magic Johnson makes a big difference, right? Like when he comes out and becomes an advocate and shows that you can still live a normal life. So maybe it's Magic Johnson, maybe it's someone else, maybe it's not a specific person, but a specific medicine that came around. What do you think were some of the key turning points as our society has begun to grapple with this?
Well, I think, the first treatment, experimental treatment for the first drug was in like 1986. Like my uncle was on the experimental treatment when he passed. So I think first that there was a lot of research, a lot of funding that was going into research, and so the treatment coming out in the mid 80s. I think in 1990, the Ryan White Care Act came about, which put a lot of federal funding into providing care for people living with HIV. And it's actually an amazing system of care. It really is. I think it came out of a group of advocates who pushed very hard, and I would say the gay community absolutely was a big part of who pushed hard for federal acknowledgement of HIV and federal commitment of dollars. But the act was named after Ryan White, a little boy who had HIV and had gotten it the same way my uncle had gotten it. He was a hemophiliac. And Ryan White became kind of the poster child for the funding. And I think when people saw a child who had innocently, and I put that in quotes, innocently gotten the disease, that also got a lot of attention. And so that was a big turning point. Then I think in 1995, there was great progress with treatment. So medications really changed in 1995, and they became, I don't know, it was the hope. It was like, oh my goodness, people can really live with this, with this disease. It was still challenging until, gosh, I don't know what year it was. It's probably been 10 years ago when the first single dose medication came along. And so I think some of those, I think the experimental treatment in the mid 80s, I think protease inhibitors in the mid 90s, which really changed the course of treatment. And then when we got to single dose treatment, and where the medication was so good that one pill a day, could make a difference. And then I think the concept of definitely Magic Johnson. I mean, Magic Johnson brought it to people's attention, like, oh, wow, it doesn't have to be a gay person. It's a famous person who's beloved, and he can still play basketball, and so I definitely think Magic. I mean, there's been a lot of famous people come out with HIV, but I think people still go back to Magic Johnson. So I definitely think that was a turning point. And then I think more recently, HIV prevention through treatment. So this idea that if people with HIV are on the medication and they're taking it consistently and their virus is controlled, they will not pass it on to other people. So it's so effective. Treatment is effective for prevention. So it doesn't just take care of the person who has the virus, but it prevents them from transmitting it to other people. And that was really a breakthrough for the prevention efforts in our country. Before that, it was all focused on behavior change. And, getting people to change their sexual behavior, it's kind of like getting people to change their eating and exercise behavior. Like, these are things that are so, part of who we are as people. And it's very hard to say, you shouldn't do that, or you should always use a condom. And so I think being behavior focused on HIV prevention helped some, but I think what really helped is this medical treatment as prevention. So that, I think those are some, and then I guess even more recently in prevention is PrEP, which is pre-exposure prophylaxis, which is using HIV medication to prevent HIV in an HIV negative person. So that's also a single dose pill every day, taken by someone who does not have HIV, but who is at risk for HIV. And it keeps them from getting it if they do engage in risky behaviors or with someone who is HIV positive. And that's a huge scientific advancement as well.
Wow, yeah. Before Paul asked a question here, I had no idea that many strides have been made in terms of prevention and preventing the spread. So that's really awesome. It's not something I expected to get out of that question. So something I learned there. That's pretty cool. So go on,
yeah,
Paula.
I learned a lot with that, because I did read a book on one of my favorite Queer Eye guys. His is Jonathan Van Ness, and he contracted AIDS, and he's in treatment, and he's not able to give it to somebody else. But your explanation really helped me understand that, because I didn't know how that medication worked. And to that point, talking about somebody who is part of the LGBTQ community, would you say that there are parallels in these movements, and what other movements could you parallel the HIV/AIDS community? Do you feel like they are an oppressed minority, or how hard is it to see this through history and how that's advanced?
Yeah. I think, and this is another, I think, draw for me to doing HIV work as a social worker is it disproportionately impacts communities who are already oppressed and vulnerable. So, I mean, certainly the LGBTQ community is already oppressed. The African American community is already oppressed. The Latinx community is already oppressed. Poor people are already oppressed. And I think, and this is what we see. We see that HIV disproportionately impacts those communities. And so I think that that intersectionality of, of being oppressed because of racism or homophobia, and being oppressed because of, or stigmatized or because of HIV, it just piles on top of people. And I think it makes managing the disease even more complicated. And one of the things that, we talk a lot about here is the social determinants of health and all the things that impact someone's health that are besides, the medicine they take, the neighborhood they live in, the income, the education, the, access to, safe housing. I mean, all these things impact a person's health. So I do think that that HIV has impacted these vulnerable communities, and they have risen up. I think it's been awesome to watch the LGBTQ community particularly really rise up and fight for people with HIV and for HIV prevention. And I've seen it in the African American community too. This disease kind of took a turn, I don't know, 15 years ago maybe, where the focus became more on, wow, this is disproportionately impacting people of color. And so, I think the African American community really also rose up and said, this cannot happen. This is killing our community. So I think that there are definitely intersections of movements, and I think that's what it takes to make change happen is people rising up, and I think that's why the HIV I guess federal program is so strong, because communities have stood up and have fought back and advocated relentlessly and have been successful.
Yeah, that's really interesting, because I mean, I know, Paula, for me and you in this class that this project is for, we just had a unit where we watched a documentary on the women's rights movement and how that movement got stalled out and struggled because some kind of, like as you were saying, like some minorities within the minority were having trouble getting traction within the broader movement, right? Like there was conflict over like whether it was the right time to also talk about the LGBTQ section of the women's rights movement, or the African American or Black section of the women's rights movement, because they have different experiences than white women do. So it's really encouraging to hear that it sounds like something similar didn't really happen with the HIV/AIDS community. It sounds like they're broader minority communities, which is a weird term to say, really like rose up around them and rallied for them. So I think that is pretty cool and a testament to those communities. So not really a question there, just a comment. So let's go on to the next thing. I want you to tell me a little bit more about your experiences as an advocate, both professionally and personally. So tell me a story or something or some facts about how you get people to understand and empathize with this HIV/AIDS minority. How do you advocate most effectively?
I think advocacy, no matter what you're advocating for, the most effective way to do it is with story and personal connection. I think, statistics and they just are not impactful for most people. So I think for me, it has been sharing my own story, like sharing, about my family, sharing about friends that I've had who, have been diagnosed, friends that have passed away. It's making it personal and helping people also see that it could happen to them or it could happen to someone in their own family. I think so much of our challenges in our society are not understanding the other. Like I cannot identify with people of color. Like that's not my personal experience. So how can I understand the struggles of people of color? Well, the best way is to be in relationship with them, right? And I think that's the case with any issue. Like if I want to advocate, for racial equality, it's got to start with relationships with people of color and understanding their journey, because it's not been my journey. It's the same thing with HIV. It's like if you cannot connect in any way, if it doesn't feel personal, if it feels like the other experience, and especially if you can place a judgment on it, then it makes it really hard to get. But if you can understand it as a person, as someone who didn't, it wasn't about bad choices, it's about the same kind of choices that we all make, right? Then I think that, to me, that's what makes a difference. Many times when I shared my own family story, people are like, especially not so much now, but especially early on, oh, you had a family member, oh, they lived with you, oh, and so I think sharing personal stories, and I think the best thing, the best advocacy is when people living with HIV can overcome their fear and share their stories. And that's hard to do. And I can't personally speak to that either. That's not a story. If I was living with HIV, I don't know, would I be afraid, to tell people? I hope not, but I can't, I can't say I wouldn't. So I think that's where the power in advocacy is. It's in the story. It's in making it personal. It's in having relationships. I remember talking with a congressman, and well, he's a congressman now. He was a House member for a while. And I took a few of our HIV positive patients to meet with him, and we were doing advocacy work. We were trying to get more funding for HIV. And the group of folks I had with me were willing to tell him that they had HIV. And his face, when they told him that, it was like, wow. And what happened is he recognized some of them. He knew some of them from his community, and he didn't know that they had HIV. And to this day, that was 10 years ago. To this day, when I see him, he reminds me of how impactful that was for him. He said, I remember being surprised at the people that you brought to me who had HIV and that I knew them. And so again, it's that personal connection that these are real people. They're not statistics. They're not bad people. They're not bad decisions. They're people, And so I think anything you can do to kind of personalize makes a difference.
But I'm wondering, how do we make people empathize when they don't have that personal connection? And how, after that, do we get involved as allies, and even if it's in a small capacity? What's your opinion on that?
I think it's really hard for people to empathize without some kind of personal story. I mean, some people are more empathetic in general, and others are less so. So, but I think telling stories, I think retelling stories, I think, if after our conversation you're like, wow, I want to do something, then I think you share stories. You learn more. I mean, there are lots of stories out there. But I don't think you can make people empathize unless they feel a connection to the humanity, right? I think people have to feel like there's some kind of connection between themselves and the other person. whether it's a relationship or an understanding or just something that says, hey, we share humanity.
I think that's the beauty of this class, this experience that we're having and everything, because we get to use these platforms to tell those stories, to reach those who are going to be able to open their minds and empathize with any minority, any misconception, any people who suffer from any kind of disease. I mean, we're seeing it now in the world. Like the current situation is proof to how empathetic or non-empathetic can human beings be. So
it actually, the COVID pandemic has been an interesting parallel to the HIV pandemic. It really, there are things that have reminded me of, the mid 80s. And I think one thing is the medical community. People, doctors, nurses, they're afraid. They're afraid of COVID. I remember doctors being afraid of HIV. There were doctors who wouldn't take care of someone with HIV because they were afraid. And I think we're seeing that now. I think providers, doctors don't want to see people with COVID because they're afraid. Fear is paralyzing. And but it has reminded me. It's reminded me of, like, you got to push forward. You got to advocate. To give people access to what they need. You got to tackle your fears. We can't let fear stop us from doing the right thing. And just even physically, just the suiting up, I've helped with some of our COVID testing, and you're putting on that suit to go out there and try to prevent yourself from being exposed, and to be the person on the other side of that, like, you're afraid to touch me. I think those there's some parallels there. Not as serious, maybe, because it's hopefully a short-lived thing, but I have seen some parallels in how we've handled the epidemic.
Yeah, some of these parallels here are really fascinating. I mean, from me and Paula's perspective, back on the stories thing and the narratively getting people to empathize, that's what this seminar class we're in. It's a night class that meets once a week, and every week we basically move on to a different movement, and we watch documentary films, and then we come into the class and discuss. A couple weeks ago was women's rights. We did Jim Crow and slavery and mass incarceration and systemic racism. We've done all sorts of those movements, right? And getting to see those documentaries that narratively present it and tell people's individual stories and give you visuals and give you emotional connect points, I think has made a big difference for a lot of us in empathizing with and understanding a lot of different movements, both currently and throughout the history of the US. So I think it's really cool that that's kind of the takeaway we've gotten from this, is that, again, it's about telling stories and about understanding people's stories and all that kind of stuff, which is why some of those famous people that have it and are out about it are very important, because they give people a story and a narrative to hang on to. Yes. So I think that's pretty cool. So before we kind of sign off and finish this up, Anita, are there any final thoughts that you want to give surrounding HIV/AIDS, the movement surrounding it, its history, Affinity Health Center in particular, anything you maybe want to leave us with on a final note?
Wow. Well, I never talk about HIV without saying you should know your status. I think part of the stigma associated with HIV is that there's stigma with getting tested for HIV. So I think, at Affinity, we provide opt-out HIV testing. That means when you become a patient here, we give you an HIV test, unless you say, no, don't give me one, because we believe everyone should know their status. So since this is a group of college kids, I would say, know your status, get an HIV test, use condoms, go get tested with your partners, practice safe sex. If you're if you're engaging in risky behavior, look into PrEP. Affinity provides it, and there are places in the Charlotte area that do as well. So I'll leave you with my HIV prevention message.
Okay, awesome. We always love a good public service announcement. Anita, we really appreciate you coming on, giving us some really great perspective on this movement. I know me and Paula definitely learned a lot about this conversation, and hopefully, at the very least, our classmates in watching this can learn a bit about it as well. So, again, we just really appreciate you taking time out of your day to get on a Zoom call with us.
Thank you. Good luck.